I see her EO on this thing, but she's muted.
Oh, okay. All right. So she may be listening in.
Kathleen,
No,
that's
Eileen.
speaking. Was I called? I didn't hear.
Sorry, Ralph. Yes. Yes, you are.
I'm here.
And say EO is who? That's Eileen O'Connor, I think.
Yes, that is.
Good. I'm here. Janine is with me. Megan Bell is on. Tanya, it appears you're on.
I am. Hello.
Great. Lori Fisher.
I'm here.
Great. Nancy Purdy. Okay, she will be on if she's not yet.
She's there. She's muted.
Okay. Anyone else on the call right now?
Dr. Joy is on the call.
Great. Dr. Joya, thank you.
Kathleen, it's Deanna. I'm on as well.
Great. Thanks, Deanna. Deanna is our quality assurance check to make sure our live stream is working. I will defer to you, Dr. Kosachev, to conduct the meeting. Thanks.
All right, thanks for participating. I guess we'll start with minutes. Does anybody have any comments about the minutes? Otherwise, if there's a motion.
This is Batman. I'll move.
Daly will second.
Thank you. Very good. I guess we'll start with Janine.
Yeah. We'll start with the bills paid on the credit card on March 30th. I want to bring your attention, first of all, to the language line. And I will tell you what a fabulous service that is. I had a chance to use the language line to have a conversation with a Spanish-speaking COVID patient, and he basically hung up on me the first time I called him, and I could tell there was a language barrier. So we reached out to him again through the language line, and it was very easy and really nice to do. So I think it's a fabulous service that we have available to us. We paid on the other credit card bill of $415.2020. All of those expenses are COVID-19 expenses. And Ray Bizzari has really helped our department with purchasing. He is a guy named Bob Janis that has done a fabulous job for the health department. And it's the health department's responsibility to take care of people who don't have a means to get their prescriptions or to have food or whatever they might need. So
While in isolation
or quarantine. And he has gone to various vendors such as Wegmans, Walmart, Maxwell's, Owens Apple Orchard, BJ's, and provided stuff for people that were necessities. And he's kind of given small businesses a little of the business and really spread it out. And it's been fabulous. He's done a terrific job. So that's what you see on 415, all of those expenses that are getting charged to the bioterrorism grant for COVID-19. And we paid Schneider Laboratory for a couple lab analysis before COVID went down. We were doing some lab checks for some kids, and we sent those out. And then we paid the regular providers for OT, PT, and transportation. that's all I have for the bills. Kathleen wanted me to just speak to the Board of Health on how COVID-19 has really changed the way I guess we're doing things and how it's affected my department. And basically, working remotely is a little tough, but we're all figuring it out. It took us a couple of weeks to get set up to do it. We're rotating only like 1 or 2 people in my office at a time. The grants, we're still monitoring all the expenses, paying the bills every 2 weeks, doing audits every 2 weeks, processing the payroll every 2 weeks, and that's really time intensive right now. A lot of the grants have relaxed some of their deadlines, but some of them are still 30 days or 60 days with no leeway. I think that's all I have. Any questions? I didn't ask if anyone had any questions. I guess somebody needs to make a
Happy birthday. Happy birthday, Janine.
Thank
That's
you,
my
Lori.
question.
Happy birthday, and I will motion to approve.
Thank you.
Do we have a second?
This is Ralph, I'll second.
Thank you. Thank you, Janine. Happy birthday.
Thanks.
All right. Very good. Shall we move on to Eileen?
Hi. So we are working from home, environmental. I probably have half the people in my office at any given time and the other half, so we're rotating who's in the office. So the things that we're working on still, regardless of whether COVID is.
It looks like we're not getting your audio feed, Eileen.
Oh, you're not? You can't hear me? My microphone is not.
Is anybody else having trouble
No,
hearing Eileen?
I can hear.
I can hear Eileen.
I can hear her just fine. Can you hear any of us?
I can hear.
Perhaps everybody turns off their audio except Eileen for the moment. We'll try that.
Okay, is this better? Can everybody hear me now? Dr. Kosachoff, can you?
I can hear you, Eileen.
Yeah, I can hear just fine.
All right, so I'll continue. So we are working on, rabies. We still have to follow up with rabies, and we're checking on biting pets to be sure that they, are healthy after 10 days. We're still following up on public water supply issues, making sure that water systems are monitoring as they should be, responding to issues. Like, for example, we just had one over the weekend where the air stripper at Union Springs malfunctioned over the evening. And so we had to talk about that and what type of public response was involved. We're also, during this time period, of course, we're not doing restaurant inspections, but we are doing mobile home park inspections because we really don't have to talk to people when we do those. We're following up on nuisance complaints, so in many complaints regarding septic systems or garbage or other issues. We are doing our septic system field checks. So if we're receiving septic system plans and proposals, and I'm sending my staff out to check the sites on those. My staff have been working on drive-by checks as part of the COVID response. So when someone is in isolation or quarantine, we need to, the health department has to verify that they're actually complying with these isolation and quarantine orders. So my staff have been driving by to make sure that people are where they're supposed to be. In addition, my staff have been involved with the COVID response. One of my staff members is in charge of the purchasing process when we have to purchase items for people in isolation or quarantine, and also to try to get a hold of PPE. Another one of my staff members has been involved with the planning function. we have set up the ICS structure, the incident command structure, as we're dealing with this COVID response. And so the planning function is one of those ICS functions. So one of my staff members is doing that. We recently have issued permits for campgrounds, and that was something that was talked about quite a lot by other counties. We're looking for guidance from the state on if campgrounds were essential. The Empire State Development Corporation, which is responsible for saying what's essential businesses that can open and what aren't essential businesses, they don't mention the word campgrounds. However, they mention alternative lodging. So there was a lot of discussion on, whether we should be issuing permits for campgrounds. And we finally made the decision that we would issue them for those campground sites that are kind of like second homes for people that they rent for the whole season. Because we did get calls that people said, well, I live down in Florida in the wintertime and I live up here in the summertime. So we did issue those permits. And what else have we been working on? Some things still keep happening. There's been a petroleum spill that potentially impacted a private well that we've been involved with. So we're still trying to do our job the best we can in this weird environment. Any questions?
Do you guys feel overwhelmed?
I guess I'm certainly not as overwhelmed as the nursing side. And I can say that I don't think Nancy Purdy has taken a half an hour off in the past 3 months. So we're feeling very busy, and we want to be supportive to the nursing side of, this issue, but we're dealing. Yeah.
I'm assuming there's going to be a backlog of things that you would typically be doing over these last 6 weeks. How is that going to impact you going forward with staff who at that point will have more work to do?
Well, we'll just have to prioritize what goes first. So one of the things that comes up in the summer, of course, are children's camps. We don't know yet whether they're going to be allowed to reopen, but they take a lot of time, and they, of course, are our priority. Bathing beaches and swimming pools, they will be our priority too at that time. High-risk restaurants, we'll have to prioritize those as compared to the lower-risk restaurants. So, we will be very, very busy once this is over, but we'll just have to prioritize what is the most important thing to do and focus on that.
Aileen, at one point, the whole issue of lead and all the increased requirements in terms of that's sort of fallen on the wayside in terms of lab results and lead results and all of that. Is that the case?
Yes, I think a lot of parents aren't taking their kids to get tested right now. So we are not getting children referred to us from the nursing side at this point.
But this is Nancy, we are processing any result that we get in, and we're still doing our 3-month, 6-month check-in with children and homes that have, had positive results. But that continues.
Yeah, everyone on caseload, you're still doing the follow-up.
Yes.
Yes.
Yes. Mm-hmm.
Does anybody have anything else for Aileen? All right. I guess thank you, Aileen. Thanks for everything. If you need anything from us, if we can help in some fashion, let us know.
Okay, thank you.
Okay. Is Lori on the call? Lori Fisher?
Hi, I'm here.
Very good. Let's move on to you. Hi, Lori.
Yes. So for early intervention, right about the 16th of March, everything pretty much ended. At that time, froze. So we were not taking, I'm taking intakes all the time, but we stopped doing face-to-face visits for early intervention, waiting to get some guidelines from the Bureau of Early Intervention through the state of, DOH. So finally, those guidelines came about the 2nd of April that authorized the use of teletherapy for those families that were able to use that method, and for the providers that felt it was going to be feasible to do. So that week of April 2nd, we started to slowly put together the platform for teletherapy. So the service coordinators really were instrumental in getting that going with those families that desired it. So about a week after that, we got the guidance from state ed regarding the use of teletherapy for those services, for related services, such as speech, PT, and OT. So again, slowly, we're getting those teletherapies up and running. We do have more kids in preschool using the teletherapy services than we do in EI, which would probably be logical because 3 and 4-year-olds would probably be more apt to sit at a video for 30 minutes with a parent facilitating than a 1 or 2-year-old. So it's slowly getting off the ground, but we are going. I'm getting some positive feedback from some, and then not so positive from others that it really isn't working as that method. So I have 4 service coordinators. 3 are basically remote. The timing was perfect about getting those Surface Pros, so they are working 7-hour days. We are doing individualized family service plans via phone, coordinating all of those, setting up those services and making sure the services are continuing on. And for those families who are not receiving services right now that were on a pause, the service coordinators are reaching out to every single one to talk about if they need any other resources at this time in regards to the COVID. So those 3, I have 3 service coordinators that rotate in on a minimal basis, and then I have 1 service coordinator, because she is an RN, we're really using during the COVID duties. And then I have 1 clerical staff is at home who's really doing a lot of billing. So her computer went home with her, so she's got everything she needs. She comes in once or twice a week to grab what needs to be grabbed in here, and then she's working remotely. And then I have another clerical here who's has been very useful on the phone. So she's been here making some phone calls. So our intakes are pretty much on pause right now, but as Dr. Archer had mentioned, we will have quite a backlog once everything is lifted and we're able to get out there and do these face-to-face visits. I have 15 EI referrals in the work queue right now, waiting to be seen. We are reaching out to these families and just talking to them about what's going on, and the parents did understand that we are pretty much pausing right now and we aren't doing face-to-face. I do want to point out that too, teletherapy was also authorized to do intakes, but at this point I'm going to roll that out really slowly and looking at how effective we can really be doing these teletherapy intakes, because we're going to have to mail everything to the parent. They're going to have to sign it, mail it back. Then the evaluations are going to have to all be done virtual. So I just, can it be done standardized? Can you really determine eligibility through a virtual evaluation? So there's still a lot of uncertainties and a lot of unknowns. But I'm trying to tackle one issue at a time to kind of roll it out slowly to see how it's going to be going. For preschool side, we are still having to pay the tuition-based programs, such as Gavris. So we are still paying those out monthly, but we are not paying any related service rates because it's a fee for service, but unless they're doing the teletherapy platform. Annual reviews are starting to roll out now for all of the school districts attached to Cayuga County, and they're all being done virtually. So like yesterday, there were like 10 that started at 8:15 and ended at 3:30, and it was like, oh my goodness. So these will make very long, tedious days. I guess that is it from EI and preschool. Any questions?
I'm just curious, Lori. Is there? I'm sure there'll be some indication that some of these timeframes, when you get back up and running, will be relaxed in terms of 45-day and all of the obligations you guys have to meet. Get the sense of that?
So those are great questions, Elaine. So what guidance we're getting from the BEI, I think, each county's probably interpret it in their own way. I am part of that Say To network, so there are 11 of us that we meet on every other week, and we're talking about, okay, how are we doing this, so we can kind of have a unified way of how we're looking at things and doing them. I think it's really going to mess up a lot of iPro reviews with all of this, and I think that's probably going to be the most relaxed thing, is really being stringent on those timelines for those reviews. So I do have these kids, and how I'm doing it when I'm bringing in an intake, I'm actually putting them into the at-risk program right now, because EI is not running, and I'm not going to say that child came in on March 30th and didn't get EI service until May 20th. So once we get this lifted, those kids that are determined at risk, we're going to roll over into the EI program, and that to me is going to start the start of their 45 days. But yeah, you're right. So I think there's still a lot of guidance we're waiting on from the state.
All right. Does anybody else have anything else for Lori? Okay. Thank you, Lori. Tanya?
Hello. So I'll give a little update on WIC. I think the most important thing to know is that WIC is open. We've been open every day. We've never been shut down. We've been providing services every day. The thing that has changed is that most of our appointments, when this first started, we were able to do some appointments over the phone. It wasn't until March 23rd that we got the approval from the state to waive physical presence at certification appointments as well. So as of March 23rd, we've gone completely remote. Thankfully, WIC has, in New York State, transitioned to the eWIC card system, so we can electronically load those benefits to those participants, which has been super helpful. On March 18th, after Aileen's email came out about the staffing reduction and the paid leave, 5 out of 7 of our team sort of fell into those categories, so they immediately started working from home. IT has been super helpful in getting us, in helping us prevent any lapse in services. So even though those staff are working from home, they are working clinic every day. Right now we're open same hours that we normally would be, Monday through Friday, 8:30 to 4:30. We're still doing some late night appointments as well, if people need them, if they're still working. So WIC is a long process. We have to make sure people are eligible income-wise and nutrition-wise. We're lucky enough to have electronic eligibility to prove that these families are income eligible. So we have access to e-cases for Medicaid verification. We have access to NICIS for immunization status and identity status. So that's been super helpful. We're also having email and texting through the secure county email and secure county phones for eligibility. All of the anthropometry and hematology requirements are being deferred to a later date. We were requesting, if they've been to the healthcare provider, that they provide that information to us, but we understand the healthcare offices are sort of swamped as well, so we were really just going to defer that to a later date to get those heights, weights, and hemoglobin tests done. We are, as Lori said, she talked a little bit about mailing. We're doing a lot of mailing. New eWIC cards are being sent out in the mail very securely, which is nice. Our peer support, so our breastfeeding support, is working remotely. They've pretty much always been the only staff who could work remotely, so not a lot has changed in their capacity, but they are there to support the girls during this time, or the families. They're also going to be holding a Zoom meetup on this Wednesday, so we're going to have our first with the Zoom meeting with our participants. Nothing has changed with the shopping experience, so That's one of the things. As much as the state is trying to do everything they can, we couldn't change the shopping experience. So WIC participants still have to go to the grocery store to use their benefits. They still have to go through a lane with the cashier. So we've been trying to give recommendations and guidance on how to shop safely. WIC is also, we've always been a referral agency. And this is kind of a priority right now, I think. At first, when this mid-March, we were getting a lot of calls about formula shortages. We were able to work with our vendor management agency, and pretty much every call that we got, if a mom couldn't find formula, we were able to connect them with a vendor manager and find that formula somewhere in the area. We posted to Facebook about the dangers of homemade formula, because we were worried that this was going to be something that families would start doing if they couldn't find formula. That post reached 5.6 thousand people, which is just unheard of for our little WIC Facebook page. But we had a lot of people calling and asking for help, and we were able to give it to them and help them find safe infant formula. That doesn't seem to be an issue anymore, thankfully. There's just a supply and demand issue. There was no real shortage of formula. The other referral that has been super helpful, and thank you to the health department staff and the county staff as well. The county website has been so useful, so helpful. A lot of participants that we talked to are recently unemployed. They're struggling with food. So we're able to help connect them with all the county agencies through that website or through that hotline. So that's pretty much a standard referral that we're getting right now is, the county is here to help support you. We've been very busy. Like I said, nothing's really changed with our schedules. So we're still providing services Monday through Friday. In February, our caseload was 1,255 participants for the month of February. This was a little low. Wasn't too happy with that. Our no-show rate was about 15% as well. Since this COVID emergency and getting the permission to do remote appointments, we've increased our show rate to 93%. So more people are showing for their appointments right now. And that, I think, trends really well with our caseload. I just did the numbers over the last month. So since that March 23rd start date for remote appointments, we've certified 120 new participants. Typically, we do about 68 in a month. So we've almost doubled our participant certification load since this has started. So a lot of work here at WIC, but it seems like we're providing really good services and people want our services, which is excellent. They're able to access our services. Our team is also, very recently just started to volunteer for the rotation for the COVID on-call, so we can help out the health department as well and get some relief there. And we're always providing messaging that the health department sort of guides us with. So those situational updates, the press releases, the information from the New York State Department of Health, we're able to pass those messages along to our participants, which is really nice. Any questions?
Anybody have any questions for Tanya? Okay. Well, thank you very much, Tanya.
I don't have anything for Tanya, but to go back to the program for special needs, I just have concerns that the state of isolation may be medically appropriate, but developmentally appropriate. But developmentally, I think we're having a difficult thing with the young children. So if there's anything from, I know that that program is already under-resourced with providers as it was. So if there's anything from a Board of Health perspective that we can do to support Lori when she is able to start evaluating these people again and to help with that from our perspective, I would certainly like to do that.
Very good. Thank you. So I guess, Tanya, if there are issues that we can help you with, by all means, let us know. All right. Very good. Thank you. Shall we move on to Kathleen?
I'm wondering, would you like me to give an overview after Nancy's been able to speak a little more specifically to her side?
That's fine. Let Nancy speak. That's fine. Yep.
Thanks.
Good afternoon. I think with this COVID, I think what I'd like to bring forth to the board is that even though the different departments within the health department have always intersected and have obviously mutual work, but with this recent crisis, we are all hands on deck for the COVID response. And I have been in awe of the talent within the department, the workmanship. It's impressive. So, and I think when we're all done, I don't think any of us will miss the disaster of this, but we will probably have to transition having not working every day together on the same project. There will probably be a miss for us. So I applaud the department for that. I probably am, it probably may be more helpful to the board if you ask your questions than rather hear me what we've done. Tell me how you'd like to receive a report from me.
So how are you guys doing in terms of supplies like PPE and testing equipment for doing the testing that you're doing?
Okay. We do have a limited source of the PPE. In fact, that's probably what we'll run out of first. And so we're looking at alternatives of what else could we do. And for instance, what we're exploring today is creating, they're almost like stalls and pecs, and where you'll the person will come to the window and you'll test them, and where there'll be no interface with the patient. That you'll be able to see each other, but the nurse will be in the stall. So I don't know whether that's a very good description, but so we're exploring alternatives to get around the PPE issue. We are currently we're updating today, new guidance came down for criteria for which testing should be done. And we embedded that into a physician or a provider assessment tool, which has been widely used through the community and well received, with the intent that we wanted to make sure that there was some provider overseeing in case the patient had a different problem. We wouldn't certainly want a strep throat to go untreated. And the physician practice could utilize it from the receptionist taking the phone call in the office and doing it was kind of a brief questionnaire and then pass it along to a provider and they could make a determination. And apparently that has worked well. We're going to update the criteria now of the choices of why you might select it to have the person swabbed. And one of the criteria is that the guidance has come down to say that a first responder first responder who has potentially been exposed and not symptomatic may get tested. So we'll incorporate that. I'm questioning whether is it still a good idea to first get the provider input? I kind of think so, but maybe I'm wrong on that. Where they could just call and schedule a test. Eventually, if we do that, we will run out of swabbing. And how often would be, sufficient to how often are we going to retest people? That's a question I have. Any thoughts from the providers on this?
So I guess I was thinking that after a provider has exposure, it probably doesn't pay to test them immediately, but I'd imagine that the protocol is to wait a few days before considering testing them, just because the likelihood of the test becoming positive is greater with time.
Yeah. Based on your response, I think, and we can always change it up. And I think another thing we've been very good at is to be agile, to take on new information and transition very quickly into a new protocol and so forth. We got to be able to do that. And so what I'm going to, based on what you just said, I just think to roll this out in respect to first responders is, ask that they get, an interaction with a provider to have that conversation. Because some of this is out of, and we understand it, it's out of anxiety and concern. And I already know that exists because I'm on first responder calls. And I know they're eager to be able to get testing, and I'm all about it, except how often are we going to test this person? How, and to have a provider have some kind of interaction or oversight over it, I think is helpful, and will be helpful to our patients. And we can always change it up if we no longer need.
Hey, Nancy, I had a question.
Yes.
Is, just for clarification, is it the case that if we had enough testing and we had enough PPE, that we would have the ability to test as many people as we wanted without specific criteria or referral from a physician? I mean, are they leaving that up to counties to decide, or is there some state guidance on that?
That's a good question. As it stands right now, so even if you compare us to Ithaca, Tompkins, and Onondaga, those two areas still, if you sign up to do their drive-through, they're asking that you have a symptom, of course, and it's all done online. You register, and you could claim to have any symptom, I guess, right? You could potentially be scheduled, but they are asking, because the criteria is symptomatology, except for the new criteria that's come down today is because we know persons can be asymptomatic, that first responders, you could test them and to be not have symptoms, asymptomatic. And what we've seen, since most of the tests have been negative by and large, we wanted to get some medical clearance because we didn't want to overlook that a patient may have, a strep throat, and not be treated for that strep throat, that kind of thing. Wanted just some oversight. And I think there will be future guidance changes, and we will change to whatever that guidance is.
Does anybody else have anything that they want to ask Nancy?
I guess one thing I was curious about and I don't know if this is for Nancy or Kathleen, but I just was reading something that Onondaga County released, and they're talking about what number or percentage of their active cases came from affiliated cases or exposure to a confirmed case. And they're saying that 60% of their confirmed cases came from where they traced it back to a contact with a confirmed case, and that shows their kind of proof that social distancing is working. Do we have that information of the 48 cases we have? How many of them we can trace back as that were community spread versus, that we trace back to a confirmed case?
I guess I would answer that with, yes, we do, because I think we do, and I'm only that we've had a couple cases that are within very close contact in their work and their living with other persons that put them at greater risk. So you could see, you could have 2 or 3 cases within that same, I don't want to use the word family, but workers or families. Yes, we've seen it we have seen it in families as well. We've had a family of 4 with 3 within a family. So we do, yeah, we have that. We see that. Yeah, definitely. Mm-hmm.
Does anybody else have any questions for Nancy? Okay.
I'm sorry, I have a question. So currently, if you have someone that you test that the provider wasn't involved with, and that clinician, whatever word we're using nowadays, and so they test negative, and you call them up and they say, I still feel bad. Under those circumstances, do you refer them to go back to a regular doctor, or if they don't have a regular doctor, East Hill, or what is the protocol for that?
That's exactly, yes, we do. In fact, we'll refer them to the respiratory clinic. We'll refer them to East Hill. We'll refer them back to their physician. In fact, that's that's a conversation that we've had. We've done a whole host of education, and that's one-on-one with that kind of thing. They're relieved to know they don't have precautions not to get COVID, but they need to go back to their physician, yes. And we also extend a quarantine and isolation. We'll extend an isolation if the person is still exhibiting significant symptoms. We'll keep an eye on them and monitor them. And we have also went to some significant lengths, I will say, to get those isolated cases into medical care if we find during the course of their illness that we think we want them to be seen. Yes. Mm-hmm. We've done significant education, and there's so much more to do. Kevin and I have gone out to businesses, to groups, and not only to educate, but to, as I tell persons, we're looking for ambassadors to help educate their families, their neighbors, and so we can get more people on the, in line to protect the community. So we've done that. We created electronic document system, if you can imagine that, to try to do that. Wonderful Maxine has that we can track these cases. We have historical data. So it is homemade, but certainly didn't want to wait around for getting anything in place. And I understand other counties are looking for something, and that's great, but we needed something much sooner and wanted to get that going. So that has worked out exceptionally well. We've been challenged with the essential worker concept, the essential worker, which are most of the positive cases are essential workers. Should be no surprise to us, right? The essential worker concept, those businesses that were declared as in healthcare essential, that was a relief because we know that there's work to be done until the rubber meets the road and they've got a positive case. And now what do we do? So we've worked with those businesses one-on-one, helping them move through and make decisions and help oversee their employees. So that's been an interesting endeavor. That's been really, I think, some good outcomes on that. And new learnings. And there are new learnings. We're all learning. And if we don't get it right today, let's work on it and move forward and make it right.
Very good. Anything else? If there's nothing else, thank you, Nancy. And we'll move on to Kathleen.
Hi, thank you. So I'm really impressed with our technology, and I will reiterate the thanks to our IT department. They prioritized us when this all started rolling out, and anything we needed, they jumped on it for us, as well as our other partners. And we can't say enough wonderful things about how responsive people have been to assist us in our efforts, including, our Board of Health. And I know that you got, being able to meet like this is really beneficial, I think, to all of us. And then I'll also reiterate just how amazing our staff is. I don't need to tell you this because you're hearing it and you're hearing all the really cool things people are doing and how we've responded and what we've done in-house and what we've worked on and how we keep doing our essential work. But, just to go back to that incident command structure, is I think we spoke about this once, but it's a FEMA structure for addressing disasters, and it can be done on a small scale or a large scale. And so we have an incident command structure that's kind of a county-wide structure, but we established one within our health department specifically, and we built in redundancies. So for instance, when Eileen mentioned that she's got someone on planning, yes, there's Michelle that's helping with planning, and there's Lori who's helping with planning. And boy, they work with each other, but they also spell each other and provide redundancy. Eileen provides redundancy to me as incident command. Nancy has some redundancy with her supervisors. It's just our purchasing, we've got a committee together, our accounting, everyone's been so flexible. I will stop gushing, but it's really great. So what's been going on a little more globally? You've heard a lot of our day-to-day with our activities that we're doing. Most recently, we have weekly calls with our State Association of County Health Officials. That's so beneficial to all of us as local health departments, and we will meet and we will talk together. And so, for instance, there were a couple counties that they were trying to purchase some software to be able to help with monitoring the number of people in isolation and quarantine. Both it was an upstate county as well as a downstate county. Now, of course, the downstate county, they have to take an entirely different approach, right? They're dealing with thousands and thousands of people, and they cannot provide the ideal level of isolation and quarantine checks. And they can barely stay on top of making sure they're getting the reports through the labs because in a timely manner, et cetera. So I think when the governor speaks of contact tracing armies, most likely there will be some capacity being used in some of these larger population counties. There's an upstate county who's looking at a software system. They're more comparable sized. they're going to see what they get. They're going to try it out. They're going to make recommendations to the rest of us if it's helpful. We also have weekly calls with our state Department of Health and all of our local health departments. And that's been very helpful because, of course, one question that if one of us has a question, more than likely many of us have the same question or a version thereof. And it's great to hear feedback right away. It's great to know what's being worked on, what's, lower priority. And then we know whether we need to make decisions within our own counties to move forward. For instance, like with campgrounds, that hasn't come out yet. It's clearly not a priority issue at the moment, even though it's, on the table. So we made some decisions in consultation. Eileen worked with other health departments and found out what they're doing. So we think we're making a practical move forward approach. We receive updates daily from our state association as well, which is fantastic. It's the links to the governor's press conferences, which typically we're not able to listen in on because we're occupied, but once in a while we can do that. But we also get summaries and we get some of the common questions and been incredibly, incredibly helpful. Locally, you're all aware, we have now our community care clinic, and I know Dr. Archer was instrumental in helping set that up along with some of her colleagues, and the hospital certainly. The hospital has also been working with us, and we've identified a means to transport people who may need to go to the clinic. Certainly, if it's an emergency, they're going to call 911 and be brought via ambulance to the hospital. But then when they get discharged from the hospital, how can we get people back to their residence? So that appears, we have not utilized it yet, but we have a method in which to do so, because previously our own nursing staff were providing this service, and that is not the best use of their time. Antibody testing. We know that we're trying to wrap our arms around it a little bit. Dr. Archer sent a great update from the Infectious Disease Society of America that I'm going to send out to all of you afterwards, because I think it's interesting. As all of you know, antibodies do not confer immunity, right? We don't have enough research at this time that's done on that. But it certainly is interesting to get a sense of who may have been exposed within our communities. Downstate, no doubt, is different than upstate, as based on kind of the dipping the toe in the water when the governor's office did kind of a surprise antibody testing in areas around New York State. And it looked like Central New York, if I recall correctly, was about a 3% rate. Yeah, okay. It may be even less here. Is it our density? Is it people adhering to social distancing? It was really, it is quite telling that the people who have tested positive, it's because their symptoms were such that they were concerning to do so, and they are your typical working age group, the most of them. I'm gravely concerned should this hit one of our senior healthcare facilities or senior residential centers. We did perform a test on a DOA who lived in a multi-unit dwelling in order to verify whether this virus may have contributed to that person's death. It was negative, fortunately, but that's a real concern that we need to be continuing to monitor. And I will say that our nursing facilities and seniors living centers are really working hard to do their best to keep this at bay. So anyways, back to the antibodies. Cortland County is working on a project through one of their FQHCs to do a study that's in collaboration with Northwestern University. One of our nurses is listening in on call right now because there's an extension branch in Moravia of that FQHC. We've got an appointment to talk with East Hill about this also. on Thursday. We know that there's some private practices who are interested in doing this. So how can we're going to try to facilitate, how can we work best together to use this as a decent surveillance tool? So more to come on that. What else can I tell you? I don't know. I guess ask me questions. I think I feel like communication is the biggest aspect, aside from the specimen collection and testing and the I&Q. That's the most labor intensive, our isolation and quarantine. But we have had such wonderful feedback from people because our staff have been able to take those few extra minutes and explain the purpose behind all of this. So we've had amazing compliance with the people who've been in isolation and quarantine. And we don't visit them at the same time every day. That's, of course, we stagger that. We don't call them at the same time every day. So it's really worked out well that way. I was part of a regional approach. Again, we spoke as about 6 or 7 health departments to offer our opinion on a plan for economic reopening. We all were kind of on the same page as far as recommendations and having a timeline in between those phases. I don't know that it will be adopted as we proposed exactly, but at least we had our voices heard. What I did find interesting, however, is as part of that, there really wasn't any discussion in that about daycares and schools. And we know there's no decisions yet about children's camps and things like that. So clearly that's a very sensitive subject. It is separate from business, but it's hard to have workers unless somebody's going to watch your children. So we'll learn more as time goes on there. Changing a lot of just new information every single day. So it's trying, staying on top of the changes as they come through. And again, that's where our State Department of Health has a great site on our Health Commerce site where they're posting all their information, and our state health organization is also acting as a great repository, but we do get emails directly, which is certainly more timely. So I guess I'll see, what questions do you have for me?
This is Ralph. Kathleen, I've got a question. Well, first, I want to thank you and everyone at the Department of Health. You guys are doing a tremendous job, and really all the first responders, the doctors, and all the public servants out there. Thanks a lot. You're doing tremendous work. The question I have relates to, one of what I think could be potentially one of the major sources in our county, in the prison system, both Auburn Correctional and the facility in Moravia. I read a story where there was testing done in one of the big Ohio facilities, and they found huge numbers of affected people. Of course, once you have employees in those systems, bringing that back into the community, then you've got a lot of problem. I'm wondering what, if anything, what coordination, sharing is being done with the Department of Health and the Department of Corrections.
That's a great question. That was a big factor across the state, particularly in our county, though, because we have the 2 correctional facilities, and I think we raised the flag sooner, and because of the initial exposure of a transferred inmate that exposed a number of workers. So a few things. I will say I had great response when this occurred. I asked a number of questions. It shot straight to the top of the Department of Corrections in the state, and I had their chief medical officer, who's one of their superintendents at the state level, who responded back readily. There's infectious disease nurses regionally, as well as in each facility, that our nursing staff now have their direct contact number. The communication it was a challenge. I think the infectious disease nurses at the correctional facilities were challenged in trying to vet out where people lived. So we tried to make their life easier and said, just give us the list and their addresses and we'll identify who are Cayuga County residents. They're essential workers. So we worked with the superintendents in each of the facilities to share with them, here's how we need you to request your essential workers if you need them to come back to work. And that's an opportunity, again, to say, assess whether it's appropriate. Do you need them? Do you not need them to come back to work? Now, because we were making, a number of questions when this all rolled out, we don't have any good counts of number of people infected within who are inmates of the correctional. And we know that the corrections system did share some data not too long ago, but obviously our greatest concern here is in the community. And on the whole, it's been a very cooperative response, but of course, everybody's got different opinions, and there's some that's, oh, you're making too much of this. Oh, this is government overreach that we're in quarantine. But, oh, well, we deal with that. Right now, the ideal communication is supposed to happen with state agencies from state agency to state agency. So state corrections should talk to State Department of Health and then should talk to local Department of Health. They're reverting back to try and accomplish that. I will say our regional office at times, I think, has been very overwhelmed by the number of counties that they're working with and the number of issues that come through their office. But they are doing their best to assist us. And the fact that we have local contacts within each of the facilities with some of the nurses goes a long way to helping us respond appropriately and quickly with people who are exposed, who are in the community.
Yes. I think we've attempted to create a more efficient system, which will be taught. We talk to both the prison and to regional to satisfy that relationship, but so we can get things more efficiently done, so we can respond quicker. Yeah, and there's just a scope of, and it's one conversation at a time of persons that are working within these facilities that are concerned for themselves and their families, and they're anxious about the whole thing. That's one issue that we talk through. Second issue is essential workers don't necessarily want to be essential workers and work in a risky environment. So we talk through that. We've worked with the prison, and I've talked to the physicians in the prisons, and I've talked to the nursing leaders in the prisons to help learn and help teach the tracking and investigation piece. And even the best of investigation and tracking, you want the best out of the gate, but you have to keep that open, because it might hear of something a week later of someone that might have, we're dependent on people's memory. So we try to help teach, that those inquiring questions to be asking. So I think the relationship is good. Not perfect. Something will come up that I'm not prepared for. I'm sure of it.
Well, it is interesting that the unique situations people find themselves in. I will also add that we have 3 times a week established a kind of county city leaders call that we host, and we hand a round robin and speak to most current situations. We have minimum 3 days a week, but often more than that, if necessary, call directly with our hospital leadership. And it had been twice a week, but our emergency management office coordinated on our behalf. And I think maybe it's reverting to once a week now, first responder calls, which I believe there's one going on
right now. Mm-hmm.
All right. Thank you. Thank you so much, Kathleen. Thanks for everything you guys have been doing. And it's really nice to sort of hear that everybody's pitching in and really trying to be helpful. And I think that it sounds like it makes for a great working environment in really trying times.
Really
So,
does.
thank you. Okay, so shall we move on to the medical director's report?
Can I just ask one question? I'm sorry. In regards to the phased reopening that is being discussed, is that thought that it might start before the 15th here, or are we looking ahead to the 15th?
You know, that's a great question that I cannot answer. I know, and what we proposed, I think that was the timeline. And when I say we, meaning regional health directors, that was a timeline that had been on the piece of paper we were working from. But Aileen McNabb Coleman, I know, has been involved regionally at that level with county leaders, and they're working with our state leadership. And I think they'll be setting some of those dates.
Thank you.
Thank you, Kathleen. Dr. Joya?
So, back on the antibodies, it's for sure. There's no guarantee if you have the antibodies that you're going to be protected, but it's probably better to have antibodies than not, especially like the long-term antibodies. And the previous studies with SARS, it seemed like the antibodies were protected with that, but it was a bit different. So we don't have firm evidence yet, but we'll see. Also, we'll see what the studies show where you give sick people antibodies to see if that helps out much. I guess HealthAid's working on that. So, might get some indirect information that way. Hopefully, if we ever get a vaccine, that will give us good information and be practical. Easier than collecting antibodies, for sure. Let's see. Testing, and the more, certainly if you're going to have people out in public, you're going to need probably testing to make a degree of safety, whether people have the COVID virus or SARS-2. Otherwise, just being cautious, wearing masks and social distancing, small gatherings or gatherings where you can space people out. In the summers, we can probably do like large open areas, easier you could gather to make sure you don't get clumping or crowding and stuff. Also remember the ultraviolet light does kill off the viral germ, and sunshine does have about with ultraviolet that would work quite well, I'm sure, for open areas. But you got to watch for things like public bathrooms and indoors and contact areas. Those still could be big issues. People are going to probably expect higher cleanliness, and I think we're probably going to naturally put a lot of resources in there. I think nobody's going to ignore it like we have in the past temporarily, but it's going to be a high priority, I think, in everybody's mind.
If I can just mention one more thing, Dr. Costa, really just to all of you, I realize, read the papers and hear what's going on. I've also reached out to the town supervisors because I think they are feeling neglected. And even though we do send them our daily updates through their clerks, and so I've offered to have a meeting with them virtually, of course. So hopefully some of their particular questions can be responded to in a respectful manner.
That sounds great. Okay. I guess before we go, we will also need a motion to approve the claims. So if anybody feels like making that motion.
I motion.
I'll second.
Thank you. Does anybody else have anything else, any additional business, anything else they want to bring up? Okay. We're looking for a motion to adjourn then. I'll make that motion.
I'll second.
Thank you very much. Thank you so much for everything you've done. Thanks.
Thank you, everyone.
You got.
Thanks, everyone.
Bye-bye.